Well, man. Hello, Dr. Cobolo.
Hello, Dr. Bennett. How are you?
How you been? Are you home?
Yes, I'm still home, but I'm traveling next week back to Zimbabwe.
Oh, okay. Well, you know, the days of travel are numbered.
Sorry?
The days that you will be able to fly are numbered.
Yeah, sure. The days are numbered.
Yeah, I don't think soon we'll be able to travel too much at all.
Yeah, sure.
I want to go visit my brother in Hawaii, which is very far, but I think I'll probably get stuck there.
Oh, okay.
But
Sure.
it's not a bad place to be stuck.
Yeah, sure.
So how you been? How you been?
I'm okay. It has been a while since I was online. Today, I wish I want also to follow the presentation. And I think in 2 weeks, I will also present.
Oh, good, good.
Yes.
We don't start for 50 minutes now, so I don't know if you have something to do.
Oh, okay, it's okay. So I will be back online later.
Okay, we see you in 50 minutes, okay?
It's okay. Thank you so much.
Okay. Bye-bye. Oh, man. Can you hear me, Solo?
Hello, Dr. John.
Hey, how you doing?
I'm cool, and you?
I'm here at the beach.
I can see that.
I'm sorry you can't be here, but that's your bad luck.
But I thought there was coronavirus there. So how do you do to be outside? Hello?
Hold on. Okay. Hey, did you get the money, Solo?
Not yet.
Did they say it's coming?
But they told me it's coming, that they're still doing some verifications, but I'll be getting it soon.
Okay, but they said it's coming, right?
Yes, they sent me
Oh,
the
good.
message.
Okay.
Yeah.
So you should have it this week, right?
Yeah. By the end of today even.
Okay.
Yes.
Okay, very good. We had a good conference, Art in Medicine from Europe,
Wow.
about an hour ago. And then this morning, we had one from Japan. We had a full conference of about 5 or 6 neurosurgery fellows from Japan. So today's a busy day. I don't have time to go to the beach. Maybe later.
Yeah, maybe.
It's still early here. It's only 1 o'clock, so it's still, you can go to the beach until around 5 or 6. It's still warm.
Hello,
Hey, Nathalie, how you doing?
Hello.
I'm good and you? Let me just
Okay,
share.
I've got something to ask you, Nathalie.
Okay, what?
Okay, is it okay if when I introduce you,
Mhm.
I say you're the only neurosurgery resident I know that can moonwalk? Is that true? Is that true?
I think it's true.
Is that true?
It is.
It is true, Zolo?
Yeah, it's true.
I can say that?
Yeah.
Solo.
Hey, you know, there's an ENT surgeon that can moonwalk. He's really good.
Seriously?
And I'm not sure if he likes it when I bring it up because he'll be at a neurosurgery online conference and I'll say, Naran, he's the only surgeon I know that can moonwalk. He didn't say anything like,
Yeah, so you don't know if he was annoyed or he was
I don't
happy
know
with
if he
it.
was annoyed or not. I don't know.
No,
But
don't
I
think
still do
he likes it.
webcasts. You know, Zolo, he's a really smart, he uses the internet really well. He's an ENT surgeon from India and he's very busy. What he does, he doesn't do Zoom, he does the Facebook Live and he
Wow.
interacts with his followers by texting.
Mm.
That's super great.
He does a live presentation, like a PowerPoint of
Yeah.
a topic. He did one in the facial nerve and, you know, anatomy around the ENT area. And he does some that have to do with neurosurgery too, because the ENT docs, as you know, Nathalie, they do
Yeah.
skull base.
Yeah.
we do
So that's
have-
one area where they share with
Yeah, we should
neurosurgeons.
share with-
There's a territory in the brain where, you know, both areas impacted.
Yeah, we share the score base with neuros. They share score base with neurosurgeons actually. Yeah.
Well, how's Ivory Coast going?
Because it's an amazing place. They are very organized, so everything is good. Everything is good.
Oh, okay.
Everything is good.
Big hospital. Yeah, you know, that helps the volume a lot. Nathalie.
Yeah, actually.
Yeah.
It does. So can you hold it up during your PowerPoint?
Okay,
She's
that's
going
what
to
I'll
do.
do.
You know, that's after you do the moonwalk. Now, is there room there to do the moonwalk? 'Cause make sure you have the space. Do you have the space there? Stand up, and then let's see.
No, I
It's
can't stand
Michael
up right now
Jackson.
because I'm painful. I'll do that next time, maybe.
Oh, next time, okay.
All
Yeah,
right.
but
You
you know,
promise.
I can break. I can break at least. You see.
Oh, there you go. That's more than I can do. But you know, white people can't dance.
Oh, you.
There you go. That's good.
From Spain, like they don't know how to dance. You know, they just shake in every sense. Like
Yeah.
they shake in a haphazard manner. So
There we go. There we go.
Okay.
Can you bust a move, Solo?
Yeah.
nope.
You bust a
I have-
move.
No, I have other moves like when we are
You
done,
need
I
a
will show
wider
them to
screen.
you. I will show them to you when we are done. Like when we are done the presentation, I will show you some of my dancing
Some of your
skills.
moves, some of your moves.
Yeah, and Dr. Ben, when are you coming to Cameroon?
That's a
Okay.
good question. Good question,
Yeah,
Zoro.
Dr. Ben, when are you coming to Cameroon?
Oh man, I would love to go to. I want to go to Africa. I look at it all the time on the internet. All the time.
All right, so you're gonna organize, and then you come.
Well, you know, I may try to go in the summer because there's a conference in Kenya.
On
Yeah, you know that
August.
what is that on that? Is that August or?
It's the 20th of August.
But you know the way the world is now, I don't know.
Yeah, we don't really know if you
I
take
don't
place.
think it's going to
Coronavirus.
happen. I don't think it's going to happen because you know
Everything
I
is
have.
just.
But you know, in Africa, it's relatively cool. So it is. There is
okay.
less.
So there's no
it was
travel
about the thing,
restrictions yet in Africa.
Yeah, we have less cases.
Not yet. In Africa, no.
Okay.
Mhm.
Okay. They seem to be changing. Italy is shut down.
Yeah.
I guess Europe, because we were one of the great
Yeah,
things
Italy
about
is
these
completely
webcasts.
shut down.
We had students from all over Europe, and they were saying, yeah, Poland's closed, and this is closed, and this. They know Europe.
I just hope to see Dr. Marco, and I hope that he's well because Italy is really bad now.
Yeah, it's got a low mortality. It's very low. It's like, as you guys know, old people and people that have weak immune systems are particularly liable, just like any flu epidemic. Well, that's the only good news in this, is that it's not a high mortality.
Yeah, it's not high mortality. It's something like 2%.
Yeah, even less than that, 1%, I think.
Yeah, less. It's around
I don't know the
1.4,
numbers yet,
1.2.
because China, it's questionable whether they give good numbers.
Hey,
Okay,
Dr. Kabulo.
Marco and Dr. Kabulo are here. Great.
Okay. I don't see the two.
Dr.
Hello.
Marco is there. Hello, Dr. Marco, Dr. Kabulo, Dr. Regis.
Hello. Dr. Marco, we're just talking about you.
Yeah.
We're asking ourselves if you're okay there in Italy.
Well, so and so. The situation is dramatic. We all close at home. The shops are all closed, so it's very hard. But we got over. I'm sure.
Yeah, North Italy got hit particularly hard, right?
Yeah. Milan is the first.
You've been on restrictions for a while, right?
Sorry, John?
You've been on restrictions for a while in North Italy, right? Travel restrictions?
Yeah, it's all closed. I cannot move for more than 100 kilometers. There are patrol, and you cannot move without justifiable reason. It's 1 month I cannot see my girlfriend.
Oh, really?
Sorry.
Wow. That's really affecting things, man.
Yeah, it's very.
Well, on the lighter side of things, Natalie's going to moonwalk before she gives her presentation.
Not today.
I don't know if Dr. Kabulo, you want us to do that? Because you're an attending, you can tell her to do it. Attendings can do that. I can't do that.
Yeah.
Okay. You ready to start, Nathalie?
Lately,
Yeah,
I've been
I'm
watching
ready.
some videos on anyone. Okay, yeah.
I'm ready.
Okay, you ready to go? Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon. It's Dr. John Bennett from Miami Beach, the studio of Neurosurgical TV. We have another in the weekly Africa Neurosurgery Grand Rounds. And today we're graced with the presence of Nathalie Gumsi, who we're watching grow up on this channel. She was a student and she attended these conferences, and now she's a resident at the Ivory Coast. Before we turn it over to Nathalie, let's meet the panelists. Hello, Zolo.
Hello, Dr. Ben. Hello, everybody. I am Zolo Ivan. I'm a CTA medical student from the University of Buea in Cameroon. I'm a member of AFAN, Association of Future African Neurosurgeons, and I'm happy to be here today. Thank you.
Very good, Zolo, a vital member of this team. Hello, Marco.
Hello, guys. My name is Marco Meloni. I'm a consultant neurosurgeon in North Italy. Nice to see you again.
Okay, welcome, Marco. Dr. Gubullo, are you there? You may have stepped away. Oh, go ahead, Dr. Gubullo.
Hello, everyone. My name is Kabulo. I'm a resident in neurosurgery at the University of Zimbabwe.
Yeah, like Marco, a frequent visitor to this channel. Regis, are you there? Go ahead,
Yeah, I'm
Regis.
here. Yeah, I'm here.
Go ahead, Regis.
Okay, hello everyone. So my name is Regis Takokam, resident in neurosurgery in Ivory Coast. So it's my first year. It's good. It's good to be here a new time for another session. So nice to meet you all.
Okay, welcome, Regis. Okay, Nathalie, welcome, and it's all yours.
Yeah, hello everyone. I'm Nathalie Gomsi. I'm a resident PGY1 neurosurgery in Abidjan. So today we are going to present on the emergency management of brain tumors. So let me just share my screen. Okay. I hope everybody can see.
Yes, we can see it well.
Okay, so as I said, today we are going to present on emergency management of brain tumors. So as introduction, we'll say that patients with brain tumors, excuse me, okay, patients with brain tumors and systemic malignancies are subject to diverse neurologic complications that require urgent evaluation and treatment. And it is essential for neurocritical care professionals to recognize and appropriately treat common oncologic emergencies associated with these malignancies. These complications are usually a result of either a direct effect of the brain tumor on the central nervous system and indirect complications of various treatment modalities. So the prompt diagnosis and timely management may preserve neurologic functions and may even be life-saving. We will start by describing the different direct effects of brain tumor on the CNS. The first and the most frequent complication is an increase in intracranial pressure, which is usually due to cerebral edema. This is as a consequence of an expanding mass lesion associated with cerebral edema. Hence, there are prominent features of high-grade primary brain tumors, such as glioblastomas and sometimes meningiomas. These brain edemas are most often vasogenic rather than cytotoxic, and the etiologies are variable. The first being the presence of vascular endothelial growth factor, which plays a key role in tumor angiogenesis and vasogenic edema formation. This VGF will also compromise the blood-brain barrier, resulting in free leakage into the surrounding brain. These VGFs may also impair the function of occluding, induce a fenestration of endothelial of the endothelium and lead to synthesis of and release of nitric oxide, which is participates in the opening of the tight junctions and enhances the capillary permeability. So on this image, we have a T2 MRI of a blood, on an axial cut of a cerebral MRI, which shows you can see the edema. This is the tumor, and the edema all around. You can see that there's even a herniation, an uncal herniation, and there's a deviation of the midline. There's a midline shift. This vasogenic edema could also be due to radiotherapy. So we have two cases here. We can have a pseudo-progressive edema, which usually spontaneously decreases in few weeks, or these radiations could also lead to vascular damage and hence radiation necrosis. And usually the edema resolves much more lately. This edema could also be cytotoxic. It is usually due to status epilepticus, meningoencephalitis, hyperammonemia, or stroke. A decrease in CSF outflow could also cause brain edema by vascular obstruction or decrease in CSF absorption. This edema also could be caused by the presence of intratumoral hemorrhage. The clinical signs are usually that of an increased intracranial pressure, that's headache, vomiting, nausea, papilledema, etc. And we could also have a Cushing reflex. A Cushing reflex is a triad which associates hypertension, bradycardia, and also a dyspnea. Usually, when you have this Cushing reflex, it signs that there's a the need to promptly act in order to reduce the mortality. So on this image, we have a brain scan on the axial cut, which shows a hydrocephalus, and we can see that there's edema around there's effusion, there's effusion of liquid towards the parenchyma around the hydrocephalus. This is an obstructive hydrocephalus. The treatment of brain edema are variable, but the main aim is to decrease the intracranial pressure. Usually, we start by general measures like head elevations 30 to 40 degrees to 45 degrees above the trunk, or hyperventilation with hyperventilation to increase the partial pressure of CO2 to 26 to 30 millimeters mercury. Actually, when you have a hyperventilation, it will lead to a vasoconstriction of the vessel and hence decreasing the cerebral blood volume. Next, what we can do is that we can use medical therapy. We can start by osmotherapy, where we can use whereby hyperosmolar agents such as hypertonic saline or mannitol create an osmotic gradient that draws water across an intact blood-brain barrier to a higher osmolarity of blood. So we can use, as I said, hypertonic saline at 3 to 23.4% concentration, or we can even use mannitol. Secondly, if that doesn't work, we can also use corticosteroids. The main corticosteroid recommended is dexamethasone, where we start by a loading dose of 10 to 20 milligrams, and then we shall give a daily dose of 8 to 16 milligrams, where that will be divided into 4 doses per day. Usually, we have a benefit here within 24 to 72 hours. And lastly, we can use an inhibitor of vascular endothelial growth factor, which is bevacizumab. This is usually done not emergently, because could be done lately to reduce vasogenic edema. If all these medical methods doesn't work, we can be brought to do Amongst the first is a tumor debulking is a procedure whereby a surgically incurable malignant neoplasm please, can you get me, or I think my net is unstable. Can you hear me?
Yeah, it's okay for me.
Okay, thank you. Tumor debulking is a procedure whereby a surgically incurable malignant neoplasm is partially removed without curative intentions. It could be done in order to make subsequent therapy with drugs, radiations, or to ameliorate the length of survival of the patient. It could also be brought to do an evacuation of the hematoma if you have an intracranial hemorrhage. We could also be brought to do ventriculostomy in case of obstructive hydrocephalus, as we said up. But we have to know that patients with glioblastomas will usually benefit from gross total resection alongside with radiotherapy and the use of temozolomide as chemotherapy usually improves the overall survival, but this is not done in emergency and an emergency. The second direct effect of cancer on the CNS is usually epilepsy or status epilepticus. It is a frequent complication of primary and metastatic brain tumors. It usually occurs early in the course of the disease, and it is the risk of its occurrence is usually inversely proportional to the grading of the tumor. In contrast, tumors associated status epilepticus most often arises later in the course and may indicate tumor progression. The administration of anti-epileptic drugs is usually there's usually a poor penetration of anti-epileptic drugs into the epileptogenic lesions. This is usually secondary to the expression of multi-drug resistant proteins by the tumor, or the tumor may interact with concomitant chemotherapeutic agents used in the treatment of high-grade tumors. Most commonly, the patients with glioneural malignancies such as dysamblyoplastic neuroepithelial tumors and gangliomas, or diffuse low-grade gliomas and glioblastomas will manifest either a status epilepticus or epilepsis. Among the patients with low-grade gliomas, those with oligodendrogliomas and the oligoastrocytomas are more prone to develop seizures than those with astrocytomas. This is due to the more cortical, the cortical and the later. We have to note that this state is usually rare in patients who have brain metastasis. The tumors, patients who have these states or epilepsy, who manifest with epilepsy with seizures, are usually patients who have tumors which are located in epileptogenic areas such as the mesial temporal lobe, the insula, on the cortex. Some molecules have been incriminated with patients who manifest seizures. Manifest seizures in their tumors, with their tumors. We have isocitrate dehydrogenase 1 and 2, which are driver mutations in low-grade gliomas and are reported to be associated with an increased risk of seizures. So studies made on low-grade gliomas, we found that there was this IDH with a high prevalence or high incidence or prevalence of seizures in these patients. Glutamate has also been incriminated, as well as GABA, as well as GABA. The treatment, as for the treatment, we realized it is being realized that older generation anti-epileptic drugs such as phenobarbital, phenytoin, and carbamazepine induce cytochrome P450 enzymes, which can accelerate the metabolisms of common chemotherapeutic agents and decrease their effectiveness, and hence decrease their effectiveness. Hence, newer anti-epileptic drugs, including levetiracetam, lamotrigine, and lacosamide, are preferred due to the low probability of pharmacokinetic interactions and a more favorable tolerability profile. We have to note that anti-epileptic drugs resistance seems to be directly proportional to the tumor grade. The higher the tumor grade, the higher the resistance. Finally, we have a direct effect. We have leptomeningeal metastasis. This is a rare but debilitating complication of malignancy with dissemination of the cancer cells in the to the whole of the cerebrospinal fluid. It can also disseminate to the pia and the arachnoid matters. It represents 1 to 2% of patients with primary brain tumors, such as high-grade gliomas, medulloblastomas, ependymiomas, and the pineoblastomas. The spread of these cells, of these malignant cells, could be either hematogenous, it could be at a direct extension, it could be a direct extension. It could also spread to the choroid plexus or a retrograde invasion along the perineural or perivascular space. The clinical presentations of leptomeningeal metastasis is really varied. So there's no clear presentation for this pathology. It usually can manifest by simple headache up to seizures. We could also have cranial neuropathies associated. But on the MRI, the leptomeningeal metastasis will manifest as we can see on the, let me take care. As we can see on the MRI, on the right, we have linear or nodular enhancement of the cerebral sulci, the cerebellar folia, the basal system, as you can see here on the optochiasmatic system. In the optochiasmatic system, it can also be invade the subependymal, the cranial and the spinal nerves. It can also cause hydrocephalus. So according to the National Cancer, excuse me, please. According to the NCCN guideline, the presence of any of the following is sufficient to diagnose leptomeningeal metastasis. If the patient has positive CSF cytology, positive radiologic findings with supportive clinical findings consistent with leptomeningeal disease, signs and symptoms of consistent with leptomeningeal disease or non-specific but abnormal CSF studies. As we said, these are the nodular enhancement of the different sulci. So this patient is having a leptomeningeal metastasis. We can see linear enhancement of the different cisterns, and here the patient is having hydrocephalus. So now the dilemma is, whom should we treat aggressively? Whom should we treat aggressively, and whom should we just treat non-aggressively? So the NCCN said found that patients who should be treated aggressively are patients with low tumor burdens, good functional performance status, lack of major neurologic deficit, no evidence of bulky disease on imaging studies, the absence of CSF flow block using radioisotope imaging, and expected survival greater than 3 months and limited extraneural metastatic disease. The aim of the treatment here is to improve and stabilize the neurologic functions, to maintain the quality of life and possibly extend survival. So here we can use the treatment could use radiotherapy, systemic chemotherapy, and intrathecal chemotherapy. We have to note that methotrexate, cytarabine, longer-acting liposomal cytarabine, and thiotepa improve or stabilize the neurologic functions, maintain quality of life, and possibly extend survival. But methotrexate, cytarabine, thiotepa, and temozolomide achieve cytotoxic CSF concentration when given at high doses, although they cross the blood-brain barrier. Hence, if administered, it's an intrathecal delivery, delivery will reduce the dose of the overall dosage of these molecules, and hence reduce the adverse effects of these molecules. Now let's pass to the indirect complications. The indirect complications are grouped in two ground groups. We have the cerebrovascular diseases and the infectious diseases. The cerebrovascular diseases represent 15% of the complication of brain tumor complications. In most intracranial hemorrhage is the most common form of stroke in patients with hematologic malignancies, while there is an approximately even distribution of ICH and ischemic stroke with solid tumors. The infarction here, first let's talk about the infarction or ischemic stroke. It is usually due to compression or necrosis of intracranial blood vessels, intravascular embolization by the tumor, hypercoagulability via tumor production of mucin, leading to formation of platelet-rich thrombi, release of procoagulant molecules such as tissue factor, cancer procoagulant cytokines such as tumor necrosis factor alpha, interleukin 1 and 6, and also due to hyperviscosity leading to obstruction of small end vessels. The second type of disease is which is the most common, is hemorrhagic stroke. This is usually due to tumoral hemorrhagic conversion. It is most frequent in glioblastomas and in brain metastasis. Here we can see an image on this T1 MRI, weighted MRI, where we can see the hemorrhage as this hyper intense image at the center of the tumor. At the center of the tumor, we can see that there's a voluminous edema around the tumor, and there's even a midline shift already. We can't even see the frontal, the anterior horns of the lateral ventricles. Lastly, these patients are also subjected to cerebral venous thrombosis. It can occur as a consequence of hypercoagulability or by direct compression or invasion of the cerebral sinuses from the dura or calvareal metastasis and the meningioma. So this is these two images we have. On the first, we have the brain scan, and on enhanced brain scan, where we can see a tumor, a parietal tumor. It's a parietal tumor, yes, which is with a hemorrhage inside the tumor, and you can see there's a large zone of edema and the midline shift. Same here with this T2 weighted MRI image. You can see an intratumoral hemorrhage. So lastly, patients could be also with pituitary adenoma could be subjected to an hemorrhage or infarction in the pituitary adenoma. This is usually called pituitary apoplexy. This is a rare but potentially life-threatening complications. So the clinical presentations of patients with cerebrovascular disease are usually those of a usual stroke patient. Usually, this can also lead to brain edema, leading to increase in intracranial. They also come with signs of encephalopathy or multifocal cerebral infarcts. As for patients with pituitary apoplexy, usually the patient will present with a sudden or brutal visual field or acuity defect. This is an emergency, or this usually a surgical emergency. So on this table, we are trying to summarize the different vascular events, the different causes, the mechanisms, and the associated malignancy. What I encircles are those which are brain malignancy, which will lead to these different complications. So we can see here that for hemorrhagic stroke, we usually find it mainly in, as I said earlier, in glioblastomas and brain metastasis. The management, as for the management of these patients, for ischemic stroke, the role of antiplatelet agents is in secondary prevention for cancer-related stroke. It remains really uncertain, so it's not really used. But they prefer the use of low molecular weight heparin product over warfarin due to the better bioavailability, and it has a longer life, and there's no drug-to-drug interaction. As for the treatment of intratumoral hemorrhages, it depends. It usually depends on different factors. That's the size and the site of the hemorrhage, the clinical status of the patient, and the presence of coagulability. But lastly, we shall talk about the infections. It is usually an important cause of neurologic morbidity and mortality in patients with cancer in general and brain cancer. There's an increased susceptibility in cancer patients due to the immunologic their immunologic status being compromised by either the malignancy or the treatment that they receive. The spread of these infections could be either hematogenous, either metastasis from focal infections, or direct extensions from surrounding structures. So usually in brain tumors, this is the main method of spread. That's direct extensions. The patient usually have some risk factors. That's a patient usually who presents with will present usually with a neutropenia less than 500 per millimeters cube, secondary to intensive chemotherapy, or the patient will even present with a bone marrow invasion. Usually, if there's a bone marrow invasion or aplasia, you have a high risk of having bacterial or fungal infections. So on this table, we tried to summarize the different different germs, the different bacteria, fungi, viruses which could be encountered in head tumors as a complication of a head tumor, a brain tumor, sorry. So we can see that Staphylococcus is usually associated with head tumors, and this is the main treatment. Also with patients with VPtions, since Staphylococcus aureus is usually an ubiquitary germ. We can also have Cryptococcus neoformans, which is usually associated with patients who have a diminished immunologic status due to chronic steroid use, or even Candida albicans or Epstein-Barr virus. So to conclude, I would say that neuro-oncologic emergencies are relatively common in patients with cancer and associated with significant morbidity and mortality. The high index of suspicion is often needed. A high index of suspicion is often needed to make diagnoses such as increase in intracranial pressure, hydrocephalus, subclinical seizures, meningitis, or venous sinus thrombosis. The rapid recognition and proper treatment can prolong the patient's life and improve functional status and his quality of life. So lastly, I will finish by this slide to say thank you all, and please protect yourself during this pandemic of coronavirus. This is Amari Francis. Thank you.
Very good. Thank you very much, Natalie. Excellent, and a good quality slides and presentation. Okay, we'll talk about later how you have to use the technology of that pointer. That was excellent. That's the first time I've seen it. We'll talk about that later. Anyways, I'd like to greet Carlos. Hello, Carlos. Carlos is a big neurosurgeon from Barcelona, or Madrid, I'm sorry, in Ecuador. Hello, Carlos, are you there?
Hello. Good afternoon for everybody.
Hello, Carlos.
Good afternoon. Good
Yes,
afternoon, sir.
Yes. Any questions or comments for Natalie? Anybody? Don't leave me hanging. Marco, any comments or questions?
Hey, first of all, my best congratulations for Natalie. It's very exhaustive. I appreciate a lot how you focalized also about infection in patients with brain tumor. I want to highlight the importance of surveillance of antipyretic drugs because I have experience of patients when use valproic acid, and in these patients, sometimes you see a deterioration. Pay attention to check for ammonemia, because in these patients, you can have some deterioration caused by valproic acid, but it's not related to the tumor, but to the anti-epileptic drugs. So check the ammonemia, and you see there is a hyperammonemia. So pay attention to this.
Thank you. Thank you. Any comments? Regis, we haven't met you. How you doing? You want to introduce yourself there, Regis?
No. Today, no. Everything is okay for me. Thank you, Natalie, for the presentation. It's all.
Okay, where are you from, Regis? Are you from Cameroon also?
Yeah, John. I'm coming from Cameroon. I'm a member of AFAN too. The last time I present myself, so I thought you remind.
But Regis, there may be one or two people watching that may want to know who you are. Hopefully, it's not a private conversation. Okay, Zolo, any comments or questions for Natalie?
Question, no. The only comment is that it was a wonderful presentation. Thank you very much, Dr. Natalie, for the quality of the presentation, and it was really an interesting moment.
Very good, thank you, Zolo. And Per, I don't think we've met Per. I don't know, Per Damien. I don't know if you can hear us. Can you hear us okay, Per? Go ahead. Well, perhaps not connected. Okay, Natalie, very good. I'd like to thank you for the presentation, and we look forward to hearing more from you in the future. And to everyone, be prepared for online conferencing, because we're going to see a lot more, Marco, of online conferences, because obviously neurosurgeons can't travel now, and it's going to be getting worse. Who knows how long it's going to last. The good news is we're equipped to handle it education-wise, because we know the platform, we know how to arrange conferences. So Zolo, what shouldn't be a hard thing to do to put together conferences for the next, who knows how many months it's going to be, where people are restricted from traveling, not only in between countries, but possibly between buildings. I don't know how it's going to get. So anyways, we'll end this chat now. Thank you everyone for coming. Okay, we stopped recording. And then Natalie, you can do the moonwalk now.
Yeah, she can.
We're not being recorded. Not being recorded.
Oh, you know nothing about.
It's just for YouTube, Natalie. Just YouTube.
We did not forget.
Come on, Natalie. It's just for YouTube. Well, how about the shake? How's that go?
Yeah, she can break. She can break.
You can break at least.
Yeah.
There you go. There you go. All right.
I think it's okay like that.
All right. Very good. Very good. Very good. That's better than the presentation.
Okay.
So Carlos, where are you at? Are you in Spain or Ecuador? I don't know if he's still there. Carlos, we do a lot of conferences together from Latin America. Hey, Carlos.
Hello.
Hey, Carlos, get ready. I think we're going to be doing a lot of conferencing from Latin America.
Yeah, at this time I'm in Spain. I'm living here, but with the problems with the coronavirus pandemic.
Yes.
We are closed in our house. It's so to understand the important to to do some
Ya está el pescado.
things.
Falta que nada.
Yeah, you know, we have a pediatric neurosurgery conference in September with Griselda. You know Griselda. I'm telling her now, we better prepare to do an online conference in pediatric neurosurgery because I think certainly, I don't think things are going to get better in the next couple of months. It looks like it's going to get worse. So we'll be seeing a lot of online. I'm going to tell her plan on it. We'll just plan on doing the conference online. So,
Yeah.
yeah. Okay. Okay. Anybody else? Regis, how are things in Cameroon? Like Zolo, people walking around. People are starting to walk around here with masks on.
Yeah, in Cameroon, everything is just normal. Like it's as if there is nothing happening. Like the streets are full, no masks. There are some few people who put on masks, but they are instead they are looked upon as if they are like aliens. Like what are they doing? So it's really super normal, and for now there is no fear. Everything is going on normally.
Right, the travels are unrestricted, right?
No, it's true. For now, the authorities say we have three confirmed cases of coronavirus in Cameroon, but nothing to get alarmed.
Well, Carlos, are you in Ecuador or Spain now? Let me unmute you there.
He said he was in Spain. He left already. He said he was in Spain.
Oh, okay. Oh, Spain. Oh, okay. Because certainly, I think things are affecting there. They're, I think, ready to quarantine the country, like they've done Italy, right, Marco? Italy's quarantined.
Sorry, Jeff?
Yeah, Italy's quarantined, right?
Yeah, we all the travel in the Italian territory are suspended. So I cannot travel in Sardinia, for example. We cannot travel. No, not at all. Not at all. Yeah. I got my brothers in Milan, but I cannot see him because I cannot move. It's all restricted.
Oh, okay.
Yeah.
Okay, very good.
It is necessary. It's necessary. I don't. I perfectly understand. So it's very hard, but it is the best thing we can do to limitate the contagious.
Yeah. Yeah. Well,
we have still the pizza at home.
Oh my God. The Italians must be suffering.
That is great. Yeah.
Oh, man. Thank goodness I live near Domino's right next door. Domino's Pizza. I'm all set. I could live here forever. And Chinese food is down the block, so I'm safe. I just have to eat alone a lot. So, okay, very good. Okay, we'll edit that and I'll post it.
Dr. Marco. Yeah, Dr. Marco, we are very sorry for what is happening to Italy and the whole world, and we are with you.
Yeah, hang in there, Marco. Hang in there.
Much, guys. Yeah. And I appreciate a lot how Natalie showed the behavioral for avoiding.
Oh yeah, Marco, I want to know that. Natalie, can you show us how you use that marker? And I want to show Dr. Kabulo that too. That's really nice.
Let me do this. So let me share again once more. So you share first.
Okay.
Okay, let me go to a slide where it's visible. You see at your bottom left, there are some at the bottom left of your diagram of your presentation.
Yeah. On your screen, yeah. Mm-hmm.
You see the third button is just like a pen.
Yeah.
The third button, just like a pen, you just click on it, and then you see there's laser point, and then you click on it.
Oh wow!
You can show it.
Wow.
So that's in
It's
Zoom,
in
right?
Zoom. Yeah, Zoom. Yeah.
No, it's not in Zoom. It's not on the.
It's
It's
not
on the
Oh,
PowerPoint.
so you're clicking that on PowerPoint, right?
Yes, it's on the PowerPoint. Yeah.
Oh, okay.
Of course, she's
You
the
see
queen.
that? You
She's
see
the
that,
queen.
Marco? You see that?
Yeah, she's the
Yeah.
queen of F1. She's only have
Hey.
to discover such things.
No, I'm not the king of anything.
Man, oh man, you can
All
moonwalk
right,
and you can do that. Jesus
she can
Christ, I'm
moonwalk. She can discover
multi-talented.
pointers.
Please.
I mean,
Multi-talented.
we
I'm
are
busy.
blessed to
Can
have
you
her.
moonwalk and do that at the same time?
Okay, guys, it was a pleasure being there. I have to leave you guys. Thank you very much. See you
Thank
next
you.
week.
Thank you, everybody.
Bye bye.
Thanks, Marco. Thanks, Regis. Thanks, Natalie.
Bye
Bye-bye.
bye.